Good afternoon, everyone, and thank you all for joining us here at Jonas Nursing and Veterans Healthcare for our 2020 webinar series. And just so you know, please remember that this webinar is being recorded. We're so happy to have you all with us today. We hope everyone is staying well and staying healthy during this time. As you can see, we are working remotely. I am Dr. Althea Hicks. For those of you who don't know me, I'm the Grants and Programs Manager here at Jonas Nursing and Veterans Healthcare. And we are the signature program of Jonas Philanthropies, which is our organization founded by Mr. Donald and late Mrs. Barbara Jonas. And our program works in partnership with nursing schools around the country to identify and invest in high potential doctoral nursing scholars. So we're so excited to have you all here with us today. We're the first and only privately funded program in the nation, and with a presence in all 50 states. And we're focused on commitment to the nursing profession and veterans healthcare, and we funded over 1,200 scholars around the country to date. Please be sure to follow us on our social media sites. On Facebook and LinkedIn, you can follow us at Jonas Philanthropies. On Twitter, you can follow us at Jonas Impact, and on our website at www.jonasphilanthropies.org. Also, feel free to visit our media library and check out our upcoming events on our website. Today's webinar is entitled Patient-Centered Opioid Tapering, and our speaker will be Dr. Erin E. Krebs, who is the Chief of General Internal Medicine at the Minneapolis Veterans Affairs Healthcare System. She's also a professor of medicine at the University of Minnesota. Just as a reminder, we would ask you, if you have any questions, please use the chat feature and type your questions in there. And then also please remember to make sure you are on mute. Thank you all so much again for joining us. And now we'll turn it over to Dr. Krebs. Dr. Krebs, you're on mute. Don't remember to, can you unmute yourself?
Go. Found it. Sorry. We always have to have these problems at every webinar, I swear. No matter how many times you've used any particular platform, there will always be the muting error. So.
Right. It's always something, but we work through it.
Great. Well, I'm very happy to be here today. And you're seeing my disclosures here. I have no industry relationships to disclose. And I'm just going to start with a few pretty basic background slides because I know this is a diverse audience, including clinicians and people who are maybe more focused on policy and that kind of thing. So just to get everybody on the same page, I always like to start with talking about chronic pain, what it is. At its most basic, chronic pain is defined as pain that occurs on most days for at least 6 months. And given this definition, it affects 1/5 to 1/3 of US adults. So this is just an enormous number of people. Of course, when you think about numbers like that, you can recognize that most people who have chronic pain are not disabled by chronic pain, are able to go on with their lives and manage their pain as an ongoing condition. The people that we hear the most about that I will focus on today, and the people who generally are the ones who are prescribed opioids, are those people with high impact chronic pain. And this is terminology that is relatively new, that was really developed to distinguish between people who have persistent pain and those who have persistent pain that really affects their activity and participation in life. And this is a smaller number of people, but it's still a relatively large proportion of Americans, perhaps up to 5% of US adults. So not a small thing. I also just like to point out, because I think we frequently underestimate the importance of chronic pain, that low back pain is the #1 cause of disability in the US and worldwide, and it is the most expensive health condition in the US, and that's in terms of healthcare spending, not even all of the work loss and other kinds of implications. So we really spend an enormous amount of time, and there's a huge burden associated with these conditions. Considering that, we really have not, I think, as a country, invested enough in terms of research and public health focus on chronic pain. Opioids, of course, are natural and synthetic relatives of morphine derived from the opium poppy. And these, are ancient medications that really humans evolved with opioids, frankly. We have used these for millennia for acute severe pain and also for end-of-life suffering. Importantly, those are indications for which opioids are typically used short-term. It's a much more recent phenomenon that we've been prescribing opioids chronically, long-term, for chronic pain. And I think at this point in time, we're really starting to depart the era of what I would call opioid-centered pain care. And it can even seem strange to people or hard to imagine how we got started on this pathway. Last week I had a medical school small group course that I was teaching, and I think the students just can't even imagine why we did the things that we did. 15, 20 years ago, it seems so crazy to them. And so I just like to show that, while there was, I think, a big story as to how this became normal and typical, for most clinicians, we were simply following the guidelines at the time. These are the original VA DOD clinical practice guidelines for management of opioids for chronic pain, and you can see how broad the recommendation was in 2003. Opioid therapy is indicated for moderate to severe pain that has failed other therapeutic indications. And for something like back pain that really, is not a curable condition, usually is something we manage over time, that applies to many, if not most people who have severe back pain. We never find the one solution for these folks. And so opioids ended up being prescribed very broadly. And part of this was this impression of an ethical imperative to relieve pain, which unfortunately I think failed to recognize the ethical imperative to avoid harm and the suffering that, overuse of a medication with serious adverse effects can cause. Of course, this was based on opinion, not research. In 2010, the next version of the guidelines had much the same recommendations. And again, very little improvement in the evidence at that time. What really changed, of course, is the onset of the opioid epidemic. We're facing a newer pandemic now, but the opioid epidemic does continue to rage. This is sort of an ancient slide. I've just kind of kept it in all my talks rather than updating it because it shows how we started. We started with this gradual increase in opioid sales, which unfortunately was tracked right along, was followed by increases in opioid overdose deaths and admissions for addiction treatment, opioid use disorder treatment as well. I mean, we got into this mess really because of our failure to do a good job with chronic pain. So I'm going to shift gears now and just present a case here to frame today's discussion. This is a middle-aged female veteran. I work in a women's clinic in the VA, so most of my patients are women. And, kind of a standard new patient visit for me, coming in saying I need my pain meds refilled as the chief complaint for the visit. And this is a patient, a veteran with long-standing problem with chronic back pain, major depression, chronic insomnia, type 2 diabetes, obesity, sleep apnea, and smoking. And for many, many years has been on a standard dose of long-acting morphine, oxycodone acetaminophen, which is otherwise known as Percocet by brand, and clonazepam, a benzodiazepine. And, when she was a new patient, just reviewing through her chart, I saw that she was adherent with her visits and refill requests. Check that prescription drug monitoring program and see that she's only used one prescriber in the VA pharmacy. And her urine drug test results are consistent with her prescribed medicines, not showing anything that shouldn't be there. She reported her current medications were helpful for pain and really the only thing that had ever helped her, although her pain was still very severe, a 10 out of 10, she said. And the medicines, she also felt like she needed to sleep, but her sleep was also really poor, waking up multiple times at night and often sleeping much of the day. She reported that she used her medicines exactly as prescribed, did not ever drink any alcohol or use illicit drugs. She was sedentary, mostly due to pain, able only to walk about 1 block outside the house, using a scooter to get around, and not working outside the home due to back pain related disability. So, looking at a case like this, we know we're supposed to weigh the benefits and harms of our medication treatments. And here you look at the list of harms and risks. Given her high opioid doses and the concomitant benzodiazepine, she has a very high risk of respiratory suppression, potentially leading to inadvertent accidental opioid overdose death or traumatic injury. Opioids, we know, can worsen depression and sleep apnea, her other chronic conditions. She acknowledged having side effects of constipation, fatigue, and low energy, although she didn't necessarily blame those on her medicines. She had some intermittent withdrawal symptoms, sure, when she ran out of medicines, but also sometimes, just when she left home without her pill bottle, went a couple extra hours, she could end up really being very sick before her next dose. And then, she had children and grandchildren and neighbor children in her home and intermittently, and so concerned about risk of inadvertent diversion to kids and maybe an overdose there. So lots of risks and harms. And meanwhile, on the benefit side, hard to come up with much. Really poor physical function, persistent severe pain, and poor overall quality of life. I mean, really, maybe the only thing you could say here is that she was personally saying that she was satisfied with her treatment and didn't want it to change. But hard to say how that's going to really outweigh all these risks and harms. So, I know that this is not really an interactive opportunity. I can't ask you to raise your hands for these, but just in your mind, which option is most consistent with the guidelines as you understand them? Would you say that it would be appropriate to continue her current opioids because she reports they are helpful and there's no evidence of misuse? That's A. B, guidelines would recommend tapering her opioids, starting with a 20% dose reduction today because the risk of overdose is so high with her current regimen. Or C, guidelines would suggest we discuss with her the risks, benefits, and adverse effects of opioids, recommend tapering, and assess her readiness to taper. So the answer is C. I'll give it to you. This is the patient-centered opioid management option. And, when I say patient-centered opioid management, this is something that actually freaks a lot of people out. And I think that's because we get confused about what patient-centered care really is. I took this definition from Crossing the Quality Chasm, a seminal work by the Institute of Medicine. And, that defined patient-centered care as care that is respectful of and responsive to individual patient preferences, needs, and values. So explicitly, this is not just a customer service thing, and it's not an alternative to evidence-based care. I think of patient-centered opioid management as considering the evidence of potential benefits and the harms in the context of patient goals and values. And indeed, this is reflected in the CDC guidelines for opioid prescribing. So I think a lot of people read it as just saying we need to taper folks if benefits outweigh harms. But really what the guidelines said is that if benefits do not outweigh harms of continued opioid therapy, clinicians should optimize other therapies and work with patients. That's my highlighting there. to taper opioids to lower dosages or to taper and discontinue opioids. So really recognizing that the patient needs to be involved in this. It shouldn't be a unilateral sudden move. And subsequent clarifications on the guidelines have fleshed this out a bit too. This is from the HHS Guide to Opioid Tapering that was released about a year ago now. And it just recommends really how clinicians ought to think about opioid tapering in a patient-centered way. And these are some of the key points from that guidelines: that clinicians should discuss with patients their perceptions of risks, benefits, and adverse effects of opioid therapy, and include patient concerns in taper planning. That if the current regimen does not put the patient at imminent risk, tapering does not need to occur immediately. That it's important to take time to get patient buy-in. And that including patients in decisions such as which medication will be decreased first and how quickly tapering will occur is an important part of the process. So I'm going to talk about why we should consider tapering this patient, why we should recommend tapering. In the next part of this talk, I'll talk about how to do that and how to involve the patient in that decision as well. So in terms of why tapering, I mean, I think there are a couple obvious reasons. First, I think it's pretty well publicized right now about the harms of opioids. I'm not going to spend a whole lot of time talking about that. I will talk more about the limited benefits of opioids, because to me, that's actually the most compelling issue, especially for patients. This harm is coming with very little positive trade-off for people. So one slide on dose-related opioid harms. There have been many studies published in the last decade or so looking at all the harms associated with opioids. And a common theme is that the higher the dose goes, the more intensive the therapy, the more the risk and the harms. So specifically looking at deaths, unintentional opioid overdose deaths, among patients prescribed opioids, those deaths increase the higher the daily dose goes, when opioids are combined with concurrent benzodiazepines, and also actually for long-acting versus the short-acting opioids. And this may be for a couple of reasons. First, the long-acting opioids in general come in higher dosage formulations. So if you really want to get to a high dose, you need a long-acting opioid. Also, those drugs hang around in the system for a long time. So it's easier to make an error or make a mistake or have the medication build up and not be metabolized efficiently. Higher prescribed opioid daily doses also predict a lot of other harms besides death, including incident and recurrent major depression, incident opioid use disorder or addiction, and road trauma. So that's enough about harms. I think they're pretty well publicized at this point. What about benefits? I mentioned earlier the guidelines that recommended opioids for moderate to severe pain that hadn't responded to anything else. Those guidelines were based largely on expert opinion as opposed to research evidence. Since those guidelines were published, there have been quite a few trials of opioids, mostly opioids compared with placebo, and mostly short-term trials. And this is a large and thorough systematic review, one of the most recent very high-quality reviews. And just to summarize what they found, when they looked at all of the trials of placebo versus opioids, pretty clear that opioids are better than placebo. This is something we would hope would be the case. But that difference is pretty small. In a meta-analysis, it's 8 points on a 0 to 100 pain severity scale. So this is a small difference, again, between opioids and placebo. The difference in function is really tiny. It's the point of being vanishingly small, 2 points on a 0 to 100 scale. And then there's really no clear relationship of opioid dose with pain effect. So higher doses of opioids in these trials did not seem to be more effective than lower doses. Further, the longer duration studies seem to show smaller benefits. And this, is likely because of opioid tolerance. As people take opioids on an everyday basis, they lose their benefit. The body accommodates to the opioids, and they just do not work as well. The same meta-analysis combined studies that compared opioids to another analgesic. There were not nearly as many of these kinds of studies. The largest group were the 9 trials that compared an opioid to an NSAID, and those found no difference between opioids and NSAIDs in terms of effectiveness. So really, opioids are not better than other medications for chronic pain. This is a trial that I led. It's the SPACE trial. And this was the first trial that compared opioids versus non-opioids over the course of a year. Now, this is not a standard clinical trial where you compare one drug to another. In this study, we compared basically all the opioids on the VA formulary to all the non-opioid pain management options on the VA formulary. We enrolled 240 VA patients who had chronic back pain or hip or knee osteoarthritis pain, and we randomized them to either opioids or non-opioid medication therapy for 12 months. In both groups, the patients got individualized medication management in a collaborative care model with the goal of trying to find the combinations of medicines that worked best for them, given the group they were randomized to. And we did a great job including keeping patients in this study, and we're able to include 238 of them in our outcomes analysis. The bottom line is that we found no difference in the primary outcome of pain-related function between the opioid and the non-opioid group. The non-opioid group actually did have statistically significantly better pain intensity, although the difference in size was small. And the non-opioid group had about half as many bothersome side effects. So a different kind of study design, but really a consistent message with the classical kinds of clinical trials. Opioids not better than non-opioids. Observational studies actually, I think, have some additional value because these tend to look at how people do over the long term in real life practice. And in studies that have been controlled, opioid therapy really has been associated with poor outcomes in real life practice. So what you see is you see worse quality of life and function over time for people who get opioids compared with those who do not get opioids, and for those who get higher dose opioids compared to those who get lower dose opioids. You also see more long-term disability and less return to work in patients who get opioids, after work-related injuries and that kind of thing. So, I mean, the big picture, both in clinical trials and kind of in these real-world observational studies, really does not support opioids being better for pain. I'll just finally just give you a quick picture of an ongoing study that I'm leading. It's called the EPOC study, Evaluating Prescription Opioid Changes in Veterans. We enrolled more than 9,000 VA patients in a prospective cohort study. It's a nationally representative sample of VA patients who were receiving long-term opioid therapy for chronic pain in 2016. And the goal was really to see what happened with these folks in terms of their patient-reported outcomes as practice was changing in terms of opioid prescribing, with a goal of seeing what happened among those people who were tapered or their opioids were discontinued versus those who continued on opioids over time. And this is just baseline data We looked at what people were receiving at the start of the study. And I'll tell you at baseline, the range in terms of the daily opioid dose was about 2 milligrams a day to about 1,000 milligrams a day. So a very wide range in this 9,000 veteran population. About 3/4 of them received only short-acting opioids, and about 1/4 received long-acting opioids. Among those who got short-acting opioids, what you see here on the slide is the different color bars represent low dose, moderate dose, high dose, and very high dose. And their baseline pain-related function was worse in the folks who were getting the higher doses at baseline. Again, this is in that short-acting only group on the left. That was a statistically significant trend from low dose to high dose in terms of higher doses being associated with worse pain-related function. In those veterans who were getting long-acting opioids on the right, their overall mean dose was higher, and they overall had worse pain-related function. But we did not see that dose trend in terms of comparing low to moderate to high to very high dose. In general, this group just had worse pain-related function than those who received short-acting opioids alone. So, this is an ongoing project, and we're looking to see now how the pain-related function and quality of life reports have changed, as many of these patients have been tapered off their opioids or had their opioids reduced over time. Because, does tapering improve outcomes? We just still don't know the answer to this question. Interestingly enough, this has just not been a topic of research until very recently. I think because when we started with all this opioid prescribing, we didn't imagine we would ever stop it. Or perhaps we thought it was a thing you could quickly stop and start without trouble. Unfortunately, that hasn't turned out to be the case. This is a systematic review published a couple of years ago that looked at all the papers published on patient outcomes of dose reduction or discontinuation of long-term opioid therapy. The inclusion criteria in terms of the studies included in this review were really liberal. And the reason is that there were so few high-quality studies. We found 67 studies that reported outcomes of opioid reduction or discontinuation, but most of them were low quality. There were only 11 trials, and they were really quite small. And there were only 8 controlled observational studies. So most of the studies included were uncontrolled observational studies. We focused on the fair to good quality studies to summarize outcomes. Most of those studies evaluated either an interdisciplinary pain program or a behavioral intervention. And the key findings are summarized on this slide. Overall, the quality of evidence was quite low. The interdisciplinary pain programs and behavioral interventions were effective at reducing opioid doses. And in all the studies that looked at pain, function, and quality of life outcomes, those outcomes actually improved during and after opioid dose reduction. So this is encouraging. And the caveats, of course, is that these findings really apply to patients who agreed to participate. So all of the studies looked at volunteers, either for research or volunteers to participate in a tapering program. The promising interventions really involved close follow-up, and in many cases, interdisciplinary support, say with mental health providers following along. And none of the studies reported about risks or adverse effects of opioid dose reduction or discontinuation. So this was a big gap. And, I think it is worth really considering what are the risks of opioid reduction or discontinuation. So very little research on this, but, anecdotally and clinical experience suggests that the things that we see are withdrawal syndromes, psychological distress, suicidality, opioid poisoning or overdose, and sometimes other drug poisoning or overdose, as patients, maybe are desperate to address their symptoms and substitute alcohol or other drugs. And what I think this brings us to is this really difficult overlap that in clinical practice we often see between patients who have chronic pain, which I've already talked about, opioid dependence, and opioid use disorder. And just to spend a minute on definitions, opioid use disorder, you know, is the DSM-5 diagnosis that replaced opioid abuse and dependence, which are really kind of addiction, you know. And of course, the terminology is very confusing, and we're trying to avoid stigma here, but sometimes it gets to the point where we can't quite figure out what we're talking about anymore. So although addiction can be a stigmatized term, really, at least it's very understandable. So essentially the concept there is addiction. Then there's opioid dependence, which again, confusingly in DSM-4 was sort of conflated with addiction. But you know, opioid dependence is a much broader concept. Sometimes described as physical dependence, which maybe is too narrow. But really, opioid dependence, the way I think of it, is the physiological adaptations that many people experience, probably most, if not all, people experience when they use opioids long term, especially in higher doses. I think of this really as an adverse effect of long-term opioid use. Opioid dependence tends to often be defined by the withdrawal when you take the opioids away, that people don't feel well. And we often think, I think, about the very acute kind of physical withdrawal symptoms like, you know, vomiting, diarrhea, goose flesh, runny nose, that kind of thing. But in patients with chronic pain, really the most prominent things are hyperalgesia, return or worsening of pain, dysphoria, really emotional pain, and lack of well-being, which can just feel incredibly, make people feel incredibly desperate. I've had people tell me, you know, I've never felt suicidal in my life except for when I run out of opioids, and then I just, you know, I feel intensely suicidal and it goes away as soon as I get my next medicine dose, you know. So a miserable feeling. And, you know, kind of reward deficiency, which, you know, sounds kind of clinical, but really what we're talking about here is, you know, the inability to get pleasure from the things that normally we feel pleasure in, you know, whether that's relationships with other people, you know, a good meal, that kind of stuff. Just the inability to feel that pleasure from, you know, from things other than opioids. We don't know enough about this concept, but it's clear that it may not be completely reversible in all patients. I mean, at its most fundamental, that's, I think, why we think many people with addiction need lifelong opioid agonist therapy. And that may apply to people without addiction as well. Opioid dependence is definitely a major barrier to opioid dose reduction or discontinuation. And we can address it somewhat by tapering very slowly or pausing tapering. But for some people, you know, that may just not be enough. It's interesting how I think individual the experience of withdrawal can be. And just to get a sense for how this can go badly when I think opioid dependence or opioid use disorder aren't considered when tapering. This is a study that was published last year. And what they did was they took advantage of a situation that occurred in Vermont where there was a policy change requiring patients on Medicaid who were on high-dose long-term opioids to have their opioids drastically reduced or discontinued. And the authors of this study identified 694 Vermont Medicaid patients who had been on higher dose long-term opioids above the cutoff that this policy had identified. They found almost 500 who had their opioids discontinued after the policy was put into place. And so what they did is they looked at the time to discontinuation as a predictor of opioid-related adverse events as the outcome. the figure just shows that time to discontinuation was associated with adverse outcomes. So the top line was the fastest discontinuation group. The time from the start of the taper to discontinuation was less than 3 weeks. And they had certainly the most adverse events. What's particularly shocking is the percent with an adverse event in that group was 3/4. Overall in this study, you really see an alarming practice pattern, I think. Almost 50% had an opioid-related adverse event, and these were mostly emergency department visits for which the patient received a substance use disorder diagnosis. Whether it was truly a substance use disorder or really just kind of an iatrogenic bad occurrence as a result of rapid discontinuation of opioids, hard to say. But most of these people just had their opioids stopped without a taper. So to go from 120 morphine equivalents a day to nothing in a day or just a couple of weeks is a really dramatic occurrence, which would make a lot of people feel terrible. Notably, half of this group actually did have an opioid use disorder diagnosis before discontinuation of their opioids, but almost none of them got treatment for that. Less than 1% received treatment for opioid use disorder. They just had their opioids removed. So this is bad care, and that hurts people.
Oh, goodness. Okay, well, Dr. Krebs, I know you've shared a lot of information with us, so thank you so much. This is not the end. I just want to interject with a question that we do have. And so we have someone asking, is there any literature that shows any differences in practice, changes in opioid prescribing in female veterans, particularly combat female veterans, and also women with back pain?
So, I am not aware of literature that specifically, so I'm going to assume that the differences there are looking at differences between, for example, male and female veterans. Mm-hmm. I'm not aware of literature on that. So the study I showed you earlier, the EPOC study, we have some ability to look at that. That was a study where we selected patients. We selected them by facility and by primary care provider within facilities so that we would have a representative group across the country. And we do have the proportion of women in that group is representative of the proportion of women in VA overall. It's a little challenging because in VA, women veterans are purposefully selected for primary care providers who are women's health primary care providers. So it tends to be a very small number of clinicians at each VA that takes care of the vast majority of the female patients. And one thing about opioid prescribing is it does tend to be very clinician dependent. If you look at predictors of, for example, high-dose opioids or opioid tapering, often kind of the strongest predictor is who your doctor is, who your prescriber is, as opposed to any patient characteristics. You'll have clinicians who have a certain pattern of practice that they apply across their patient population. And so I do think in VA, it's going to be a little challenging to look at gender differences because what they really may be is a reflection of that smaller group of women's health primary care providers versus other primary care providers in VA. But we will at least try to take a look at those.
Sure. Okay, that sounds good because I think that's something that, may come up every now and then. And then also we had another question about research related to maybe the psychological or mental health relationship in terms of the use of opioids. I understand you did share research about the clinical aspects and, how they are used for the clinical feature, but in regards to it relating to the psychological aspect, is there any relationship there? Maybe sometimes patients think they need to have the opioids when they're not experiencing as much pain or the threshold may be higher. Is there any discussion or any literature that you know of about that?
Yeah, it's a good question. And I do think that there are really important relationships there. So we know that people who have a history of depression, of PTSD, of sexual trauma, of combat trauma are more likely to receive opioids, to be prescribed opioids. And we know that honestly, opioids do alleviate emotional pain. So, you know, it, it's challenging, I think, to separate physical and emotional pain, because in reality, the pain circuits in the brain are really, you know, there's no distinction there. It's not a separation. You know, people feel pain and suffering, and nobody can tease apart, you know, what is the pure physical from the more psychological or emotional, because, you know, it's all in the brain, in the nervous system, encoded there. And I think trauma in particular is very important in driving opioid use, and the persistence of opioid use. And I think trauma and sexual trauma and post-traumatic stress symptoms are really important barriers to opioid discontinuation. For patients who I've worked with, sometimes those recurrent trauma symptoms are worse than any recurrent pain symptoms they might have when they're trying to come off of opioids. You know, opioids can dull those feelings that are so aversive for folks.
Thank you. That's definitely a good point. And then we have one more question before we continue. Are there any education programs provided for health providers in terms of their prescriptive practice of opioids, and are they held accountable for their overprescription of opioids?
So, you know, I'll speak to VA specifically, has established something called the Opioid Safety Initiative, probably about 10 years ago. And, you know, this is not an initiative that punished anyone, but it did try to make those patterns explicit in terms of who is prescribing, you know, who is an outlier in terms of prescribing higher dose opioids to more patients, and what facilities are outliers there. And just sort of publicizing this information and trying to reset norms. It is challenging because, you know, I think what is often the case is that you want to point out that someone's practice is no longer appropriate or is high risk for their patients, but you don't want to push them to cut their patients off. And this is such a difficult balance, I think, to help support clinicians to reduce opioid use in a patient-centered way, while not encouraging things like patient abandonment or drastic one-sided reductions in opioids.
That's a good point. Wow, that's very helpful. I know we'll probably have more questions, but we'd like to let you continue. So
Right.
whenever you're ready.
Great. So just to summarize this first part, benefits of long-term opioid therapy don't seem to outweigh harms and risks for most patients with chronic pain. Collaborative, well-supported tapering may improve quality of life, although there's very little research on this to date. And abrupt one-size-fits-all opioid reduction or discontinuation probably increases risk of opioid-related harm. And then just that protracted withdrawal associated with opioid dependence and opioid use disorder or addiction that's been unrecognized previously may complicate efforts to reduce or discontinue prescribed opioids. So we always need to be alert for these things, because these are the patients who are the most likely to really suffer an adverse outcome. So now I'm going to switch to patient perspectives on tapering a bit. You know, it's hard to summarize in a talk, but there have been a lot of qualitative studies looking at how patients think about opioid use, about tapering opioids, about opioid discontinuation. And this slide just highlights some of the key messages from those studies. Really, I think a strong theme in many of these studies is that patients really want to be treated as individuals, not according to policy. So as many policies as we have had discouraging opioid use, a lot of patients feel like we're just treating them as a one-size-fits-all. You're doing this because it's the VA said you have to, not because you think it's the best thing for me. Another thing is that patients clearly have different perspectives on harms than we clinicians do. I think a big thing is that clinicians, we tend to focus on overdose and addiction. And those are really important outcomes, but kind of infrequent, relatively speaking. Patients, by virtue of their experience with these medications, not having experienced addiction or overdose, generally think of their risk of those things as being low. On the other hand, what they have experienced in the past is uncontrolled pain. They've experienced withdrawal and suffering. They are fearful of those things because they are more real to them. Also, loss of control and abandonment by a prescriber are big factors for patients when thinking about opioid discontinuation or reduction. Overall, the balance of factors that affect the quality of life of an individual patient may be much more salient to them than severe or uncommon harms. And this slide is just comparing some of the most common patient-reported desired outcomes of pain management with some of the most common undesired outcomes of opioid therapy also reported by patients. And you can see how, these things can track to each other. So patients hope that pain management will not just give them relief of pain, but also improve their level of energy and their emotional well-being and all kinds of things. And the opioids often have side effects that directly impair those kinds of other domains in terms of their symptoms and well-being. So this is a model developed by a primary care physician of patients' taper experience. And this was based on qualitative work. And what I kind of like about it is, taking a model of what generates taper outcomes, you notice that, things like the prescribing aren't in here at all. This is really all about the communication and support for patients and their own taper strategies. It acknowledges that, how we talk with patients about tapering feeds into how they approach it, and that their strategies and the work they put in tapering is very important in driving outcomes of tapering. So when we say we're going to taper a patient, what we're really asking, sometimes without acknowledging, is for them to put a lot of work into managing, changes in their life related to pain, activity, medications, emotions. And we need to really consider this when we think about how we enact a tapering plan. So guidance for opioid tapering that has come out of these studies of patient perspectives provide individualized rationale for dose reduction. So don't just say the guidelines say so. Say, talking to you, I think this is the best thing for the following reasons that are personal to you. Address patients' concerns about pain, withdrawal, and abandonment, and then involve patients in developing the taper plan. So this means considering their social, emotional, and health factors, discussing how they may manage the work of tapering, helping them problem solve with that in advance, and develop a taper plan with provisions for adjustment based on patient response. So the way we operationalize this is really through a process of shared decision making. And shared decision making is a concept that I think often gets applied to big decisions like, chemotherapy or surgery, but, can also be applied to small iterative decisions about management of chronic conditions. At its most basic, this is a process that includes 3 steps. The first one is bidirectional information sharing. The second one is just deliberating about options. And the third is agreeing to a course of action. And this can be iterative, something you do in little bits and pieces over a long period of time. It doesn't have to be a one-time big event. Importantly, it does not require a prescriber to give up the decision authority over something so important as controlled substances prescribing. You can focus the shared decision-making where it's appropriate. And as an illustration, I always like to just think about the fact that, you know, most decisions to stop opioids are entirely one-sided. They are made by patients, because most patients who we prescribe opioids to just quit them on their own because they make them feel worse. So, you know, up at the top here, this is an arrow sort of illustrating the degree of decision sharing from a patient alone decision at the top to a prescriber alone decision at the bottom. And then, you know, the ideal perhaps in the middle, the perfectly equally shared decision. Well, most opioid discontinuation is a patient decision. Maybe they experience nausea and constipation, and so they just stop the medicine and tell us later. On the other hand, you know, we always remember the ones that we make ourselves. You know, say there's a drug test that is positive for cocaine and negative for a prescribed opioids, you suspect diversion, this is a, you know, high risk event. Well, a prescriber would stop opioids at that point without consulting with the patient. You know, probably there aren't too many perfectly equally shared decisions. Most are somewhere along the spectrum. The case that I talked about earlier was this patient on morphine, oxycodone, and clonazepam for many years. And risks of these therapies were clearly outweighing the benefits, but there was no evidence of opioid misuse or imminent overdose or other serious harm. So this is a case where it's probably a decision that may be more on the prescriber side. You know, this is non-urgent, but it's important. No prescriber wants to continue a therapy that is causing more harm than benefit. At the same time, you want to take time to involve the patient in the tapering. So I would say this is more of a prescriber-led decision with patient involvement. And for this patient, you know, getting started on that pathway, that first step of sharing information, these are some of the questions I ask a patient, you know, so the questions in black italics are the questions for the patient trying to elicit their sharing. The ones in blue are me sharing. So I always try to ask patients, you know, what would you like to do that you can't do because of pain or because of opioid side effects? How would your life be different if your pain was well controlled? I mean, these are questions that can help you get at their goals and values, what they would hope for, and what you might want to target with your treatment plan. And then trying to get to some of the concerns they may have. Have you tried to cut down on opioids before? Have you ever run out of opioids? What happened? Do you know anyone who has tapered off their opioids? So that you can find out their concerns and address those. And then I think an important part of information sharing is being clear about your agenda. I'm recommending tapering because I'm very concerned that these medications are causing you more harm than good. I don't think they're really helping your pain much at all. And I'm concerned about all the side effects you're having and that you could have a worse outcome in the future. My hope for you is for you to be able to get back to all those valued activities you're not doing anymore. That's what I want to focus on. And my definition of success, well, you know, I would like to see you be more active and engaged with your life. I don't have a specific dose target for you, but I think it should be lower than what you're on right now. So this is the step that really takes the most time in shared decision making, and maybe it never stops. You know, you always hope to be sharing information. Step 2 is really deliberating about the options. And I think for a clinician, the important thing is, you know, what options do you want to put on the table? I would not say to this patient, do you want to reduce your opioid use or not? Because I'm going to help her reduce her opioid use. That's a decision I'm going to make. But, you know, when we start doing that, which drug we start reducing first, how fast we go, what other kinds of goals we work on, how frequently we follow up, those are all decisions I would like to work with on her. So I'll put those on the table and deliberate about those options, not about the option of keep everything the same. And then the final step is just to agree on a plan. But again, this can be one small decision at a time. So in this case, what happened with this patient is that we tapered off her morphine over 2 years. That was the first thing we do. So, you know, I did not do this rapidly at all. After we got the morphine down, then we started reducing the oxycodone. We went down from 8 tablets a day to 3 tablets a day. And that's where we stayed. I never was successful in getting her psychiatrist to change her benzodiazepine prescription, so it is what it is. And we did have to taper the pause the taper several times over those 3 years or so. Sometimes because she had an increase in pain, but dramatically she had an onset, kind of a recurrence of severe PTSD symptoms, and we really did have to pause so she could get mental health care for about 6 months, and then she was ready to start back up again. So the outcome for this patient was that her pain really, you know, if you asked her, she'd say it was about the same. But she was so much better in terms of how she managed her pain on a day-to-day basis. And she had dramatically improved her physical and social function. She also had a lot fewer opioid-related symptoms. So some of the things like fatigue and constipation and nausea that were going on kind of went away as we reduced her opioids. And so we got her off of some of the other symptom-based medicines she was on too. You know, before I finish, I always think it is very important to say, since I've been focusing on medications, that medications are only one part of chronic pain management. This slide just shows a lot of the non-pharmacologic therapies that are available, and these specifically are therapies that VA determined had sufficient evidence that they should be broadly available to veterans. So exercise movement therapies, behavioral therapies, and manual therapies, lots of conservative options that can be used during and after tapering process. For the patient in the case, honestly, the thing we did the most was walking. We just focused on walking, and a gradually increasing walking prescription over time was probably the biggest non-drug therapy we used. There's nothing fancy about it, but you know, it got her moving and she eventually started to feel better. So summary of patient-centered tapering. These are just kind of the keys. Take time, learn about the patient's values, goals, and priorities, elicit and address patient concerns, share decisions whenever you can, start slow, go slow, follow up frequently, and don't forget to use non-medication and self-management strategies. And I just put a couple good resources for you on there, and that's it. So I'm happy to chat more if there are any more questions.
Well, thank you so much. I think that information you shared was very helpful for our audience. I definitely agree that I think sometimes we don't consider the other factors or the other types of treatment that you use in collaboration. And so it's good to see that this is something that is being considered as well. When it comes to opioid tapering, you can look at what other factors can help the patient in doing that again. We do have one question. Someone's asking about if you can show the step 2 slide again. And I'm not sure if you would like to make your slides available, then you know, you can let us know about that and we'll provide them for everyone. So would you want to go over that real quickly?
So I'm happy to share my slides later. So this was just this shared decision-making step 2, which is deliberating about options. I blew past this. Now, sometimes I give this talk to an audience of people who I know are prescribers of opioids who are really doing this. And we tend to spend a lot of time on what options should you talk about patients with. I always think one of the most important ones is just which drug to start with. So this was a patient on morphine, oxycodone, and clonazepam. Each of those drugs individually and the 3 together in particular are all increasing her risk. And so, you know, her risk could be decreased by addressing any one of those. And so I just kind of put it out there. Tell me how you feel about these. You know, do you feel like one is more valuable to you than the others? One that doesn't work as well? And she identified the morphine as the one that she didn't really feel like it was making much of a difference. And so that was where we started. And, you know, so again, it took us 2 years, but we tapered off that completely before we started tackling the other medicines.
Right. That's really good. I think, you know, definitely, you know, you have to do some form of assessment and making sure, like you said, it's a shared decision making between the patient and the healthcare provider. And so we have someone else asking about benzodiazepines. So they're asking, you know, listening to the presentation, you can see a lot of connections between the way opioids and benzodiazepines are prescribed, as well as the concerns associated with tapering. Do you feel that we may see a benzodiazepine epidemic the way we did with the opioid epidemic?
I do think there's a lot of similarity there. And, you know, actually, maybe the benzodiazepine epidemic happened first, right? Wasn't that the classic 1950s overprescribing epidemic there? And it was, you know, benzodiazepines have always been so gendered in their prescribing. You know, just that I think women are overprescribed benzodiazepines. Pretty impressively, and certainly women do seem to have, female patients are more often prescribed benzodiazepines and opioids together, which is a particularly bad combination. In VA, benzodiazepines are a big problem because they are often used for PTSD symptoms, as well as insomnia and anxiety. And they're very difficult to taper, I find. You know, I've had some experience tapering benzodiazepines and find it more difficult, honestly, than tapering opioids. Yeah, it's tough. There is so much in common because, again, they're not preferred treatment options, but once they're started, they can be so hard for people to come off.
Wow. Well, that's definitely something to think about, you know, in terms of our audience. We know there are many nurses and other healthcare providers out there, and, you know, dealing with this whether you're dealing with different patients with different health conditions. You know, it's interesting because it sounds like some of the same practices and techniques that you provided would still apply in terms of assessing the patient and the shared decision making. So at this point, we have reached our time. So we do want to definitely say thank you again, Dr. Krebs, for all of this great information that you've shared with us today. We appreciate you taking the time to provide this presentation for us. And to our audience, thank you to all of you for joining us today and spending time with us here at Jonas Nursing and Veterans Healthcare. Again, just as a reminder, the presentation today has been recorded and it will be available in our media library on our website at www.jonasphilanthropies.org. So again, we thank you all of you. Thank you everyone for joining us. Continue to stay well and stay safe. Have a great day.
Thank you all. And I'm Erin.Krebs at va.gov. And
yes.
Please send me an email if you have any questions or anything I can help with.